This module will teach the proper technique and clinical relevance of orthostatic vital signs. Orthostatic hypotension occurs in a variety of clinical settings. Obtaining accurate values may have a significant impact on patient care because clinicians base their management strategies on these results. Accuracy is essential. By the end of this module, learners will list 5 common causes of orthostatic hypotension. They will explicitly describe the proper technique to perform orthostatic vital sign readings, and they will correctly interpret the results. A common complaint elicited in the outpatient setting is acute dizziness or lightheadedness, which is frequently associated with an acute illness and a common condition encountered in the emergency department and the inpatient setting is acute kidney injury. In both of these situations, one of the most valuable assessments is orthostatics to help determine volume status. In performing orthostatic vital signs, instruct the patient on the process of obtaining orthostatic blood pressure measurements and its rationale. Assess the patient's ability to stand. Have the patient lie in bed with the head flat for 5 minutes. Measure the blood pressure and the pulse while the patient is supine. Instruct the patient to sit for 1 minute. Ask the patient about dizziness, weakness, visual changes associated with position change. Check sitting blood pressure and pulse. If the patient has significant symptoms with position change or a sitting blood pressure of less than 190/60, stop the test. Ask the patient to stand. Again, ask about significant symptoms or feelings of fainting. If so, stop the test. Measure the blood pressure and pulse immediately after the patient has stood up, and then repeat the measurement 3 minutes after the patient stands. Support the forearm at the heart level when taking blood pressures. Assist the patient back to bed. When compared to a supine blood pressure measurement, after 3 minutes of standing, a fall in systolic blood pressure of greater than or equal to 20 millimeters of mercury, or a diastolic blood pressure of greater than or equal to 10 millimeters of mercury, or a rise in pulse of greater than 30 beats per minute is abnormal. A persistent decline past 3 minutes suggests a more significant abnormality. This is more commonly seen in neurocardiogenic disorders, which typically are chronic as opposed to an acute problem. A blood pressure drop immediately after standing that resolves at 3 minutes does not indicate orthostatic hypotension. However, this finding may be useful to confirm the patient's complaints of feeling dizzy upon standing and may lead to patient education about using caution when arising from a lying or sitting position.